to traumatic brain injury management guidelines. As I told you, this has been there for a while, not changed much, though there are small revisions that have occurred. And the small revision that has occurred is only on the ICP number. Okay, the number is changed, that's all. But otherwise, it's largely remained the same. So there are three phases. Okay, when you have traumatic brain injury, there are three phases. The first phase is hypoperfusion. The second phase is hyperemia, and third phase is vasospasm. And why you need to know this? Because the treatment is directed accordingly. Okay, so in the first couple of days, what interestingly occurs is a drop in the perfusion. That means cerebral perfusion is going low. Since cerebral perfusion is going low, our entire treatment is based on reducing your ICP, because CPP is equal to MAP minus ICP. So our first couple of days is completely focused on reduction of ICP. You got the point? Our first couple of days is completely focused on reducing ICP. That's how you defend your CPP. Meanwhile, what I will also do in this case, I will definitely prevent the MAP from dropping down. I will definitely prevent the MAP from dropping down, and I will try to reduce my ICP. That's how I will defend my CPP. So all what I do at this stage in the first couple of days is this. Okay, this is what I'm going to do. In the second phase is hyperemic phase, where you can cause problems because of excessive circulation. So I will try to optimize my CPP, and then comes a least known phase of vasospasm, which we don't know what to do at this stage. We don't know also when this stage comes. This stage kabhi aata hai humko pata bhi nahi. Okay, that's why transient Doppler might help you in those stages, but we do not know also when this stage comes usually. Okay, and that is the phase where you maintain the CPP. But for us, remember this: first couple of days, MAP you have to defend, ICP you have to reduce. After that, you have to optimize. Clear? After that, you have to optimize. Clear? Three phases. There are three phases of traumatic brain injury. So there were multiple guidelines. Multiple guidelines came in, and the Journal of Brain Trauma came up with the last revision in 2007. After that, there has been one more. So there are a few things that you must understand. First of all, application of all the evidence as a group. You need to do. Everything has to be done as a group. Whatever guidelines are put together, you have to do it all together. You can't do it separately. It can't be done in silos. Okay. Initially, what used to happen? Ye karo, chalo wo karo, chalo ye karo. Different piecemeal guidelines were there. When 2007 Brain Trauma Federation came up with the guidelines, they put everything together and said, this is what you need to do for TBI. You understand? Initially, it was different. All piecemeal was there. Now instructions were there. Do this for this. Do that for this. Then they came up with the guidelines saying, do all of these together, then these patients will kind of improve. And that is why adherence to a protocol, they decided to form a protocol. So adherence to a protocol based on BTF guidelines, which we are going to discuss now, can result in a significant decrease in hospital days and for TBI who live more than 48 hours. Mortality and outcome also changes. This is what they did when they formed the protocol. That's where we have to figure out what the protocol is all about, and actually it has got all these evidences. So the Brain Trauma Federation guidelines have got all these evidences in place, all these guidelines, recommendations. But remember this, there is only one level 1 recommendation. There is only one level 1 recommendation which says don't use steroids. Don't use steroids. There is only one level 1 recommendation that says don't use steroids. So there is so many recommendations. There is about blood pressure and oxygen, will come to that, hyperosmolar therapy, prophylactic hypothermia, infection prophylaxis, DVT prophylaxis, indicated ICP monitoring, ICP threshold, CPP threshold, brain oxygen monitoring and threshold, anesthetics, nutrition. So many these are there, but only one level 1 evidence says do not use steroids. That is the most important thing that it comes to traumatic brain injury, because of the fact that the use of steroids has actually caused more amount of problems. So the crash trial that came out, it said in patients with moderate to severe TBI, high dose methamphetamine associated with increased mortality. So it's contraindicated. You understand? If tomorrow you have a TBI and somebody puts a steroid, you must tell them, boss, don't do this, it's increasing mortality. You never do that. Clear? And that comes from which trial? It comes from a trial called as a crash trial. One of the largest trials ever done in traumatic brain injury or for matter road traffic accidents. So this is they looked at all patients with head injury, GCS less than 14. Okay. The primary outcome was death at 2 weeks. That was the primary outcome. 10,000 patients they looked at, 10,000 subjects. Multi-center randomized controlled trial. That means it was done very extensively in various centers. They gave methylprednisolone 2 grams and then they loaded it, uploading 0.4 grams per hour for 47 hours. They did that. So what did they say? So those patients who received the steroid, the mortality was higher than those who did not receive the steroid. Very simple. So you don't want increase in mortality for certain. So what will you not do, Kunal, now? You will never use steroid. Okay, never use steroids. Very, very important. Okay, and you normally see them giving steroids. You see people who don't understand, they give steroids. Okay, so you're not supposed to give steroids at all. Now you did talk about hypoventilation. Now you did talk about hyperventilation. Now remember this, you can never do it prophylactically. Never and never do hyperventilation prophylactically. ऐसा नहीं कि patient TBI के साथ आया तुमने उसको hyperventilate कर दिया. नहीं करना है. It is not supposed to be done. You are not supposed to hyperventilate your patients. Clear on this here? Clear on this? You can do it temporarily. Temporarily, provided the patient has got a blown pupil. Okay. Say for example, surgery is posted at 2 o'clock in the afternoon. You have come at 7 o'clock in the morning. You came and you found out that one pupil is dilated. Okay, that means it's a clear indication that there is raised intracranial pressure. If there is a raised intracranial pressure, then I will hyperventilate my patient because the quickest method to reduce ICP is hyperventilation. The most quickest method to reduce ICP is hyperventilation. Clear? But then there is a caveat to that. How would you do this? How would you do this hyperventilation? So remember this. What happens with hyperventilation is that you need to ensure that the PCO2 is somewhere around 32 to 35, not less than 30. So when I say hyperventilation, you are not going less than 30. Your PCO2 is what? 32 to 35. You understand what I am saying? But the hyperventilation, normally you are hyperventilating your patients. But most of the times your ETCO2 is on the lower side. Isn't it? So you have to mention PCO2 at 32 to 35. It can't be less than 30. And that is very important for you to understand because this graph will now understand. Okay, we just discussed PbTO2, right? We just discussed PbTO2, Lycox monitor. Okay, so this graph is Lycox. Okay, this graph is ETCO2 and this graph is cerebral perfusion pressure. Now we are taking an example where the patient you have hyperventilated. So when you are hyperventilated, what has happened? After 10 minutes, the ETCO2 has dropped to less than 20. See this? It has dropped to less than 20. ETCO2 has dropped less than 20. The moment you go less than 20, what are you seeing? You are seeing the cerebral perfusion to go up. Unfortunately, the PbTO2 is going down. See this? That means the actual reason why you are hyperventilating was to actually reduce the ICP so that perfusion increases. But what is happening actually? The PbTO2 is actually going down. You understand? So your CPP may be getting better. Why is your CPP getting better?
Edema is coming.
Huh?
Edema is.
How it is reducing?
Because of hyperventilation.
Edema reducing. तेरे को अगर if I hit you here, edema कम होएगा क्या तेरा एक मिनट में? नहीं होने वाला ना. तो ये कैसे कम हो रहा है ये? How is the hyperventilation working? What is actually happening? Huh? So what is happening is where your brain has got a very beautiful reflex. So the moment you hyperventilate you hyperventilate and remove carbon dioxide, there is vasoconstriction in your brain. There is vasoconstriction in your brain. So it's not because of edema coming down. Your brain has got only three parts. It's got brain, it's got CSF, and it's got blood. Only three things are there. If I want to reduce my ICP, I have to reduce one of these components. Okay, I can't reduce the swelling of the brain. That is going to take ages for it to come down. Okay, what I can reduce is the blood component. Okay, so when I do hyperventilation, there is vasoconstriction, and because there is vasoconstriction, the blood in the brain actually reduces. You understand? Since the blood in the brain is reducing, that is why the ICP is coming down. Clear? Have you understood this? Clear? So that's how this kind of things works. Okay, but what is important is if you were to hyperventilate them excessively, there is a drop in the PbTO2. There is a drop in the brain tissue oxygen, and the regional cerebral blood flow is actually going down. The regional cerebral blood flow is going down when you are actually doing hyperventilation. Clear? And that is the reason that you need 30 to 35, and that's why hyperventilation is something that you will be very scared of. For example, look at this. Look at this. This is a xenon perfusion cerebral blood flow. You can actually find out cerebral blood flow by doing xenon perfusion imaging. Okay. Now this is a patient whose cerebral blood flow is 59. Okay, and his ICP was 44 and the PCO2 was 45. You hyperventilated this patient to PCO2 of less than 30. Okay, and what is happening? See, ICP is coming down, but look what has happened to cerebral blood flow. 14, almost ischemic. So if you want to actually come down and you hyperventilate your patients, there is going to be cerebral ischemia because it is vasoconstriction. You understand vasoconstriction, and that is the reason you cannot aggressively hyperventilate your patient. You can't do that. Clear? Huh? Clear this? That is why if you want to hyperventilate your patient, what do I want to do? I want an SJVO2 monitor. Now you've understood why you want the SJVO2 monitor. Why? Because if I want to hyperventilate this ischemia, I will notice it in my SJVO2. I will notice my SJVO2. Understand? So if I want to hyperventilate my patient therapeutically, I will monitor my SJVO2 because it will tell me ischemia. Now you know what is SJVO2, isn't it? So that is where hyperventilation comes in. So you can't empirically hyperventilate your patient. If you want to do so also, you have to be bedside, standing there and looking whether the PCO2 is going less than 30. If you're going less than 30, stop doing it because it's going to cause ischemia. You're understanding? So it's not wrong to catch a ammo bag and do first. It's very, very wrong. Very wrong. It is very wrong practice to do that because you are creating ischemia. You're creating ischemia. You understand what I'm saying? Huh? So you have to have controlled hyperventilation. And one other way to control hyperventilation is stand bedside, look at the ETCO2 and look at your SJVO2. Clear? Huh? Clear on hyperventilation? Then the next step. Very important to avoid hypotension. As I told you, the first phase is a phase of hypoperfusion where there should be no drop in mean arterial pressure. So that is why you have to avoid hypotension and importantly avoid SpO2 of less than 90 and a PO2 of less than 60. Very interesting this is. So this is Chestnut and Nino Stockady, beautiful trials. So this was an emergency room trial where they sat on a helicopter. Whenever the patient was getting airlifted, they sat on the helicopter, they monitored the saturation. Okay, and what they found was and they monitored blood pressure. So they found out when there was hypoxia, the outcome of these patients is very, very bad. See, 33% chance of death. Right? So when there is hypotension, there is a 60%. When there is both, 75%. You see what has happened? So if there is saturation drop more than 90% or there is hypotension, the outcome becomes very, very bad. Just oxygen saturation also outcome is very, very bad. So at any given moment, your saturation should not drop. Should not drop in traumatic brain injury. It's not like any other case. Okay, it cannot drop. That's why it's very important that the saturation is maintained. Otherwise, you will have this patient in a vegetative condition later on. This severe traumatic brain injury will have vegetative condition. To prevent that, you have to defend your map. Okay, you have to keep the map on the higher side. Clear? You have to keep the map on the higher side. Never allow it to drop, and saturation never allow it to drop. Clear on this? Clear on this? Huh? So there is clear value. The impact study said the same thing, that the blood pressure has to be optimal, can't be very high, can't be very low. This is what it says. Can't be very high, can't be very low. Okay. So we feel now that a higher systolic BP may be a better option. We think like that. No? ICP is high, slightly higher is better. Obviously, norepinephrine has taken over from. If you want to raise the blood pressure, use norepinephrine. If the blood pressure is on the lower side, but dopamine causes arrhythmogenic tendency, so we don't want to use it. And it is important to use normal saline for resuscitation in these patients. So give fluid, get the map up. If it's not coming up, start NORAD. Ensure that the BP is on the higher side. Clear? Okay. So which are the catecholamines you use? So definitely DOPA and phenylephrine is not what you want to use because it does not do anything as undesirable effects. Whereas norepinephrine is the one which is shown to improve global and regional oxygenation. So norepinephrine is the drug of choice if you want to raise the mean arterial pressure. Right? Now ICP. So where do you use ICP monitoring? So the indication is to use at all salvageable patients with severe TBI and abnormal CT scan. Level 2 indication. All salvageable patients who've got severe traumatic brain injury and an abnormal CT scan actually requires an ICP monitor. This is what the guidelines say. Where is the guidelines say? Because that is the way you monitor these patients. You understand? That's level 2 recommendation. And thresholds are more than 21 actually. Avoid aggressive CPP of more than 70. Here, this is what ICP is also. Somebody asks you where you put ICP. Any patient who got an abnormal CT scan, okay, and they are salvageable. Okay, that is where you use. In the rest of those cases, this is level 3, but it is also important for you to know. Severe traumatic brain injury, but a normal CT scan. With any of the two, either age more than 40 or bilateral upper motor posturing or blood pressure more than 90. So level 2, level 3 indication for almost every patient comes over here when it comes for raised ICP. Clear? Okay. So there have been many she just went through the monitoring intracranial pressure and said that it probably may or may not work. So there's a controversy on that. But the guidelines say use raised ICP. Okay. So what is the problem if you don't use ICP? If you just do hyperventilation, because prolonged hyperventilation will actually worsen outcomes. If you say, okay, let me just paralyze my patient, the ICP badega hi nahi, he will remain silent, the other side will not move, will not cough on the tube, ICP will not go up. Prophylactic paralysis increases pneumonia and stay. You can't do that. Excessive sedation has a risk of hypertension and worsening of outcome. Hypertension is very dangerous. And monitor as a variable ICP response and extent of ICP decrease and duration. Here, that's why the value of 60 is very, very important. Keep the CPP more than 60 as much as possible. Okay, you see more than 60, and of course you need to figure out what is happening in such cases per se. So clinical and subclinical seizures were reduced, and thus secondary injuries were reduced when they gave anti-epileptics. But anti-epileptics are not supposed to be given. But when you ICP target it, your seizures come down. When you target ICP, okay, your seizure potential actually comes down. Clear on this? Okay. Now, CPP targeted protocol means I am going to monitor only my CPP, I am not going to look at my ICP. So, some prospective current data said that when they actually divided SGO plus CPP and CPP alone, just by monitoring CPP, the mortality was higher as compared to when you monitor both together. So, that's why multimodal monitoring becomes very, very important. You monitor them from all angles, it becomes much better. Right. So what is the optimal CPP threshold? We said that to find the threshold, we need all these monitors. We need all these monitors. You need brain tissue oxygen, brain tissue oxygen. You need near infrared spectroscopy. You need ICP monitoring. Then only you can actually say the optimal CPP. Right. Now, for example, let me put it in in a very different perspective. When you have a patient of traumatic brain injury, what is happening? What is happening in traumatic brain injury? What is happening? Diffuse edema. So what is also happening is, what we just now talked about is from 50 to pressure map 150. Can you give me pressure map 50 to pressure map 150? There is auto regulation. That means whatever happens, nothing happens. Like for example, you have patients with 220 and 230. Sometimes they come to 230 blood pressure, 250 blood pressure, 300 blood. We had one recent patient 300 blood pressure, isn't it? When you have such blood pressure, what you're going to expect? You're going to expect that the blood is going to go to the brain and burst. 300 pressures, right? It should actually do that, but that doesn't occur. Why that doesn't occur? Because internally we have got a beautiful auto-regulation. Okay. Now, this means to say that if my pressure in my body is 200, still my pressure in my brain will be regulated. Okay. The moment this regulation goes, this is called as pressure passive. The moment the regulation goes, they go pressure passive. That means whatever pressure is down, that pressure will be on top. You understand? That pressure will, it's the same pressure everywhere. That's called pressure passive. Okay. Similarly, so that means auto-regulation is not intact. Similarly, auto-regulation is also helping that when you are hyperventilating, the vasoconstriction is occurring. That is also working. That's a regulatory mechanism. So if I study my auto-regulation, then I can decide what to do. You understand? If I study auto-regulation, that is what she was talking about by talking about PRX. Okay. What is this PRX? It is something called as a moving correlation coefficient. मतलब क्या हो रहा है मालूम है? What is PRX? I explain to you. What they do is they have these monitors in place. Okay. Then they raise the map. When you raise the map, if the ICP is going up, means auto-regulation is not intact. It's not okay. So they look at a map ICP. They look at CO2 challenge. For example, they give CO2. They hyperventilate the patient, and then they look what is happening. If you're hyperventilating, what should happen? The ICP should come down. So they study both this. They study what happens when you increase MAP. They study what happens when you hyperventilate a patient, and then they create a chart. And that chart gives you a value called as PRX. If the PRX is negative and positive, it determines whether the patient has autoregulation or does not have autoregulation. That is what is PRX. Okay, PRX is a software where you give phenylephrine and you monitor the ICP, give phenylephrine, monitor the ICP, similarly PCO2, monitor the ICP, and then it is started on a graph. इतना मैप पे इतना ET छोड़ो इतना इसमें ऐसा हो रहा है, and then it gives you a moving correlation coefficient, which is the PRX, which is -1 or +1. ठीक है, that tells you autoregulation. Now if I know my autoregulation, then I can do now whatever I want to do. Then I can tell you, okay, keep this pressure, keep that pressure, or reduce ICP size. You got the point. So that's what is regarding CPP threshold. That is how you find the CPP threshold, and that's why you need these monitors. Okay, he explained to you what is PPTO2. This is what is PPO2. This is the Lycox monitor. Lycox monitor. This is the slot to put the card. This is a brain. This is the probe that goes inside the brain. Okay, it's a brain tissue oxygen catheter. Usually it has got 3 parts. It may also have brain temperature monitoring, and it have raised ICP. This is the ICP, brain tissue oxygen, and ICP. Clear on this? This is PBTO2. This is one of the monitoring that you may want to use. It's level 3 to use PBTO2 monitoring. Okay, PBTO2 monitoring level 3. In level 3, I will either use SGVO2 I will maintain SGVO2 more than 50% or PBTO2 more than 15. That's what level 3 is. Okay, level 3. Clear? Well, what is the problem with SGVO2? We don't know which side to put it. Because it's regional. We don't know which side to put it. उसको बड़ा सा SDH अगर ये बाजू है, कंडीशन ये बाजू, तो ये बाजू थोड़ा अलग हो सकता है. SGVO2. That's why we have a problem with the side. We don't know how to place and calibrate it that well. Placement is, it's going to take time. You first put it inside, then you do an X-ray, then based on the X-ray you take a call, this is the right place, C2 level पे है कि नहीं है. Okay, then you go and hyperventilate. So it's going to be a long duration, no? And you want to hyperventilate now, the ICP already gone up. So it is a problem on that. Okay, practical problem is there. Treatment monitor only ICP as a guide is not possible. You need to have other monitors also. ICP you require. Others, how much you will hyperventilate, you don't know. How much you will hyperventilate, you don't know. It becomes a problem. And it's a global measure. It doesn't measure the whole. It measures the whole brain. It doesn't measure one certain part of the brain. ठीक है? So, alright. Next is mannitol. Okay. Now, what about mannitol? What about mannitol? Anything about mannitol? Anything about mannitol? How does mannitol work? How does mannitol work? How does mannitol work to reduce ICP?
Osmotic diuresis. Osmotic diuresis.
Sorry?
Osmotic diuresis.
So this means to say it is removing water from your body?
From the cells.
That means that is how it's reducing the brain. If that was the case, mannitol should have worked immediately. What normally occurs, how mannitol should work? When the water comes out of the body. But when you give mannitol, the water comes out of the body after 45 minutes.
Yeah.
It doesn't come immediately. It's not, you give mannitol, it takes 45 minutes. But the ICP reduces first earlier than that, so that can't be the effect. You understand what I'm saying? What am I saying? When you give mannitol, the output increases after 45 minutes, approximately. But the ICP is reducing much earlier than that. So definitely it is not osmotic diuresis. Clear? So how does mannitol work? So mannitol works by altering the rheological properties of RBC. How does mannitol work? By altering the rheological properties of RBC. What does this mean? That it creates the RBC, it makes the RBC move in such a way, the shape of the RBC in such a way that it now goes properly inside and perfuses the brain. Are you understanding? So if the question comes, how does mannitol work? So you are supposed to say mannitol works by altering the rheological properties of blood. Clear? Rheological properties, because of which you are able to move this RBC much more better inside the brain. Clear? समझ में आया? So mannitol has other activities also. The osmotic activity is the last. The first activity would be altering the rheological properties. The second is mannitol is after all molecules of glucose. So it actually perfuses the brain with some amount of glucose. The third is mannitol has some free oxygen radical scavenging, which is one of the secondary insults that you have, free oxygen radicals. So it actually gets that also under control. You understand? But unfortunately, mannitol is a dangerous drug. Why is it dangerous? Because it is also going to cause osmotic diuresis, which may cause hypotension and electrolyte imbalances. So very dangerous drug. Okay, that's why if you looked at mannitol, so people started looking mannitol and the other drug that you can use is hypertonic saline for the same purpose. Same purpose, the other drug you can use is hypertonic saline. So they started comparing mannitol with hypertonic saline. And what do you think was better? So how did they did this? How did they do, from where this hypertonic saline mannitol most of the trials have been done? The trials have been done in battlefield medicine. Battlefield medicine करके एक चीज होता है. You know what is battlefield medicine? Battlefield medicine is war area में क्या करते हैं हम लोग? So there is a whole conference that is conducted called battlefield medicine conference actually. So in that, what they found was when you are actually going to the war zone and the person with raised ICP, he has to carry buckets and buckets of mannitol. Now amount of mannitol that he has to carry is a huge amount, whereas the amount of hypertonic that he gives is very, very low. So in battlefield medicine, you are able to run across with that hypertonic saline, which is smaller amount as compared to mannitol, which is a large amount. Okay. The second thing is, what is happening when a person is in traumatic brain injury or road traffic accident or for that one war injury? He is hypotensive. When he's hypotensive, mannitol will cause more hypotension. But what is happening with 3% saline? It doesn't do that. 3% saline doesn't cause hypotension. So what came as a result of battlefield medicine? That hypotensive saline seems to be better as compared to mannitol in maintaining the MAP. So if you have a patient who comes in with RTA, with a head injury, and you have raised ICP, your first go-get drug should be hypotensive saline. Okay, that's why hypotensive saline seems to be the right technique to be used in these cases. So there have been studies where elevated ICP, which was not available to treatment with mannitol, went into 7.5% hypotensive saline, improved oxygenation and improved cerebral and systemic hemodynamics. And that's why it appears that this might be a better option. In fact, when you look at this, this is time and ICP. It is looking almost the same. If it is almost the same, that means the effect of mannitol is equal to that of hypotensive saline, and this does not drop the blood pressure, which is our basic issue. You understand? So it doesn't drop the blood pressure, and that's why it appears that mannitol, this hypotensive saline may be a go-get drug. Moreover, look at this study, okay? Oxygenation. Now this is PbTO2. Brain tissue, now we all know what is PbTO2, brain tissue oxygen. So in one case they gave mannitol, and the other case they gave hypotensive saline. So what happened? PbTO2 actually went up when you look at mannitol. So what should be the drug? At least by these studies, it appears that it actually causes an increase in the PbTO2, apart from defending the MAP. So it seems that hypotensive saline may be a good alternative as compared to this. Also, the neuroinflammatory response also comes down when you are using hypotensive saline as compared to mannitol. So there seems to be some relative effects of hypotensive saline that seems to be a little bit more better. However, head to head, there is no data that says this is better than this is best. ऐसा नहीं है. But at least biologically, it appears that hypotensive saline may be a better tool as compared to that. That came from mannitol. So that is what comes from battlefield medicine. Look at this. TBI 80 kilos. 80 kilo individual. How much mannitol 20% required? The dose is 1 gram per kilogram. That is the dose. 1 gram per kilogram is a mannitol dose. Okay, that means 80 grams. That means 400 ml. 20 grams in 100 ml. So 80 grams, 400 ml. You understand now? 400 ml. Isotonic saline compensation will be lower. You lose only 800 ml isotonic saline. So you have to carry another 800 ml. So 1200 ml तुमको उठा के लेके जाना पड़ेगा. Because you want to lose that water. You have to replace that water. Right? Whereas hypotensive saline 2 ml per kilogram, 160 ml. Such a small amount. You understand? Just 2 ml per kilo, 160 ml. So obviously the amount that you are requiring is very low. It doesn't cause all those dialysis and all those things. At the same time, it has got all those good effects that we just now talked about. Okay? And there are other arguments that says that systolic blood pressure less than 90 should be avoided. This is what we're talking. It says, the recommendation says, you cannot cause it less than 90. Most of our patients are in hemorrhagic shock. So it will drop the blood pressure. That is why, what is the drug of choice you feel? Hypertonic saline usually. At least on this way. So Cochrane review said that there is a small benefit of, actually it says it's almost equivalent. In fact, they say the mannitol is slightly better. But unfortunately, there is no clear evidence that says one is better than the other.
So clear? 7.5% hypotensive.
Yeah, 7.5%.
The ones we use 3%.
It's available. 7.5 is available.
7.5.
It's available. You can use it. It's all available. Okay. So there is insufficient reliable evidence to make recommendation the use of mannitol in the management of TBI. Okay. There is insufficient evidence as of now, as per the Cochrane database. The last, the level 3 last indication is hypothermia. There is no difference in outcomes when it looks at hypothermia. So, are we going to use hypothermia? No, we are not going to do that. Though there have been data that says Eurotherm trial also came and proved negative. Initially, there was some trial that said hypothermia does make some benefit, but the Eurotherm trial came in recently which said that it doesn't make a difference. So, at the end of the day, it doesn't appear that hypothermia may help in any which ways. Okay, prolonged hypothermia. This was what they said, that it might be beneficial. However, there is still not yet sufficient evidence to recommend it routinely. So hypothermia is also not something you would want to use. No hypothermia. Okay, no hypothermia at all. What about DVT prophylaxis? Every patient of traumatic brain injury should receive mechanical prophylaxis, and you can very well start it as quickly as possible right after the first day. Okay, right after the first day. That is what they say, that you can start it as quickly as possible. In fact, the next day when you start LMWH. Okay. Alright. Now what about infection prophylaxis? So only for intubation you require an antibiotic in traumatic brain injury. In TBI, you give an antibiotic only when you are intubating your patient. That is the only time you require to give an antibiotic. Early tracheostomy should be performed to reduce mechanical ventilation days in cases of traumatic brain injury. Early you put it, you will come off the ventilator quicker. Okay, routine ventricular catheter exchange, prophylactic antibody use for ventricular catheter placement is not recommended. So if you have a EVD in place, don't give prophylactic antibodies, it's not required. Okay, and don't keep changing it in intervals, you don't need to do that also. And it's important to early extubate your patients, very very important to early extubate your patients over there. Okay. So we do not do all these things. Prophylactic burst, just now we discussed about EEG. You don't get to a flat line. You don't do all those things in these cases. Though you might think if I flatten off the ECG, patient might get better. Okay, because we are not really there's no spikes, there's nothing. You don't do that. High dose barbiturate administration only in very very high refractory ICP. Okay, and propofol is one of the drugs that you may want to use for this case. Okay. Okay, anti-seizure prophylaxis. It is not recommended for late post-traumatic seizures. However, if you want to give it for the first 7 days, you can give it and stop it. Okay, it is not for the late post-traumatic seizures. It's not, so no need of giving these prophylactic anticonvulsants. Only in the first 7 days, you can properly give it to prevent early post-traumatic seizures. So first 7 days you can give it, but not more than 7 days. For when you look at anti-seizure prophylaxis. Clear? And damage control surgery in severe head injury. So as long as possible, do the ICP monitoring, try to do a decompression early. Rheological optimization by type of crystalloid, by giving normal saline and mannitol. Use of 5% dextrose in cases where osmolality more than 3, don't do that. Don't do 5% dextrose at all. It's not a great drug. Only if the osmolality is very very high, you will use 5% dextrose. Okay. Recommendation for traumatic brain injury vasospasm is something we want to look at per se. Autorelation guided management is not really commonplace. As we go further, it is going to come in. Okay, and if no ICP monitor frequency of CT scanning, we don't know whether you have to do it every 1 hour, every 2 hours. So this is all about traumatic brain injury. Okay. So is there any question?